My name is Lauren, and for the last 8 years, I have been a baccalaureate prepared registered nurse working within a medical intensive care unit or ICU. Now I have finally decided it is time to work towards a higher education and am pursuing my Doctor of Nursing practice in executive nurse leadership. Today you have made it to my presentation on ICU acquired weakness and how we can combat this practice problem with mobility within the ICU. I find this topic particularly interesting as my unit puts a lot of focus on providing as many opportunities for mobility as possible. However, when talking with other critical care colleagues, it seems that the other units do not. This personal knowledge caused me to wonder what the benefit of mobility is and why my unit puts forth such focus on the process. And as you will see, mobility can be a process. By the end of this presentation, I hope to have inspired your interest in what ICU acquired weakness is and give you the ability to describe why mobility is important. Finally, you will be able to use the evidence to become a change agent for your area of practice. Okay, let's talk about what ICU acquired weakness is. ICU acquired weakness is the broad term given to describe the acquired symmetric, these are our key words here, our acquired symmetric weakness in critically ill patients with no other weakness associated etiology. For instance, the asymmetric weakness you may see in a patient diagnosed with a stroke. ICU acquired weakness is a part of a larger problem identified as post-intensive care syndrome, which is the manifestation of residual difficulties associated with critical care admissions. Now, you may find yourself asking, if ICU acquired weakness is associated with a larger issue, why just focus on weakness? Well, with acquired weakness, the individual experiences a disability to independently perform tasks known as activities of daily living. Some critically ill patients never return to a fully functional capacity, and as you can imagine, this practice problem results in longer lengths of hospital stays, increase in mortality rates, and an increase in healthcare-related costs. The Society of Critical Care Medicine has reported that annually around 5 million Americans require an ICU admission. A critical care admission can last an average of 3.8 days and cost on average a total of $4,300 per day. Treatment options can become complicated through use of mechanical ventilation, sedatives, analgesics, pressors, and various other tubes and drainage devices. It only takes 48 hours for ICU acquired weakness to begin, and any mix of these complications can reduce the ability of the patient to participate either cognitively or physically with mobility interventions. To date, 25 to 50% of all critical care admissions are affected by ICU acquired weakness. As stated, some patients experience residual effects of weakness for years post-admission, while some do not recover at all. Following the identification of this practice problem, I devised a population intervention, comparison, outcome, and time question. In critically ill adults, how does progressive mobility compared to traditional bed rest affect ICU acquired weakness? Our population is critically ill adults aged 18 years and older, male or female. The intervention is progressive or early mobility. The comparison is traditional bed rest. And our time portion of the question will be important in our data collection and is identified as length of stay in the ICU admission. This becomes important because it's variable per individual patient admission needs. As you can see through this Prisma graph, my search took place in 3 databases: the Cumulative Index to Nursing and Allied Health Literature, or CINAHL, PubMed, and Cochrane Database of Systematic Reviews. Additionally, I conducted a hand search for an original artifact on the identification of the development of the ABCDEF bundle of critical care admission, which we will discuss in more detail in the upcoming evidence review. Keywords used to organize the search include critically ill or critical illness, and physical rehabilitation or early mobility, and ICU acquired weakness. I was looking for academic journals written in the English language between the years 2009 and 2020. Articles were included for consideration if they consisted of all critically ill adults aged 18 years and older, hospital stays requiring ICU admission, and ICU-acquired weakness being assessed. The articles were excluded if they focused on a specific ICU population such as trauma or neuro. They were also excluded if a single specific mobility intervention applied, such as an in-bed cycle system. 5 articles met my identified criteria, 2 primary quantitative research studies, and 3 systematic reviews, and the result in the following evidence summary. To begin, Dirks and Kozlowski identified the adoption of the ABCDEF bundle as an important step to assist ICUs in the growing complexity of critical care admissions. The bundle was built by collaborative efforts between the Society of Critical Care Medicine and the American Association of Critical Care Nurses. Now, with all of those letters, we could do an entire series of presentations on this bundle. However, today we will just focus on the E portion, or early mobility and exercise. As we have already discussed, critically ill patients begin experiencing a decrease in physical function as early as 48 hours post-ICU admission. This is a direct result of disease process and pharmaceutical effects. All 5 identified articles agree that beginning a mobility program 24 to 72 hours post-ICU admission is key. However, while the timing of when to begin a mobility program is agreed upon, a program itself has not yet been standardized. What emerged instead is a key theme our variable ICU settings can use to build a program that best suits our individual needs based on the concept of progressive mobility. Progressive mobility is just as it sounds and focuses on increasing the intensity of movement as allowed by the patient. Movements begin passive in bed, which is to mean the requirement of the assistance of a provider to move your joints, and then they continue into active movement, which is led by the patient. As the patient begins to build strength, we can dangle at the bedside with feet rested on the floor, transfer from bed to chair, and finally an ambulation can occur. According to the evidence, mechanical ventilation is not a barrier to participate, and every form of mobility, inclusive of ambulation, can be done in patients who are mechanically ventilated. This intervention takes place for at least 30-minute intervals for 5, 6, or 7 days a week, depending on your available hospital resources. As these are critically ill individuals, patient safety is of concern, and adverse events such as falls, accidental removal of various tubes, hemodynamic changes, and cardiopulmonary difficulties want to be avoided. As a result, each study revealed that active monitoring is done of patient tolerance through the standards of ICU care, such as pulse oximetry, electrocardiography, and either invasive or non-invasive blood pressure monitoring. 2 additional evidence-based tools used to measure patient tolerance and ability to work progressively are the Richmond Agitation and Sedation Scale, or RASS, and the Confusion Assessment Method for the ICU for Delirium and Coma, or CAM-ICU. Each test measures the agitation and sedation level to look at the ability for the patient to participate, both cognitively and physically, in progression of activity. Next, change. So change is not meant to be inherently easy, and this project is certainly no different. The specific challenge will be the culture of the ICU hospitalization, which is bed rest. Cotter's change model is the most fitting for an initiative such as mobility, as Cotter uses 8 clearly defined steps to inspire and create a sustainable change. This will require innovative strategies and well-built steps. All right, now there are 8 steps, so bear with me here. First, we want to create a sense of urgency. Use our background information and educate and appeal to our providers using their desire to cause no harm to their patients. Next, we want to build a committee of unit stakeholders. These stakeholders include nurses, and ideally at this stage, a clinical nurse specialist or unit nurse educator will help you the most. A physician, physical therapy, and/or occupational therapy, respiratory therapist, and pharmacist. Now, something to consider is that my unit utilizes a patient liaison or advisor. This is a discharged patient who has willingly volunteered to advise on behalf of the patient view. Now, this might be something beneficial to your committee. Once your committee is formed, use them to create a standardized practice of progressive mobility that best suits your unit's flow. Identify change agents within the unit. It is important to create a sustainable change, and these are those individuals that will be actively engaged in change and help with the identification of barriers and ultimately our fifth step of short-term wins. Barriers can be identified through documentation of patient and provider experience. The documentation will also be used to celebrate short-term wins. For instance, we do a sort of monthly superlative identifying those healthcare professionals that inspired us over the last month. The professional is presented with a ribbon or a pin and a congratulatory email by one of our unit leaders. Once these steps have been accomplished, sustainable change can occur, and what started as change will become the new culture of the unit. And most importantly, please remember that change takes time. So, how are we going to evaluate this? Looking back at our Peacock question, we want to look at ICU acquired weakness. And as you can imagine, the best measurement for weakness is its opposite, strength. There are a few ways to measure strength. However, we will be using grip strength to measure our intervention. A hand dynamometer will be used to measure. A hand dynamometer is a device the patient very simply squeezes with their hands. The measurements come out in pounds force. On average, healthy males measure between 101 to 121 pounds force, and healthy females between 57 and 70 pounds force. This is an average for non-critically ill populations. However, we need to know it so we can have an aim for our strength. Obviously, grip strength is not typically measured, so our aim will be measuring grip strength upon admission. Critical care patients are so called as their condition can change at a moment's notice. So clinical decision-making skills will be crucial here, as some patients may unfortunately not be able to have baseline data. Keeping in mind the average ICU stay is 3.8 days, daily measurement of grip strength will be important to obtain usable ratio data. Grip strength will cease collection upon transfer out of the ICU. Our data can then be placed into a t-test. Of note, there are numerous types of hand dynamometers available for purchase through several companies. This picture is just an example so you can get an idea of what a hand dynamometer is and how it works. My Peacock question was created following conversations with critical care peers and their variable clinical practice we have with mobility interventions. As a result, dissemination will be of utmost importance. Personally speaking, I work for a large healthcare system, and internal change can be quite challenging as change has to be presented to each entity's unit practice councils. Keeping in mind Cotter's change model, creating a sense of urgency for this change will be helpful during this time. A majority consensus will then need to be decided upon before entity change can occur. Following this, I would like to create an abstract to submit to the New Directions Conference based in Atlanta, Georgia, and co-sponsored by several healthcare systems there. The New Directions Conference focuses on nurse-led non-research changes, so this would be performance improvement and quality improvement studies. Finally, given the setting of critical care and the use of the SCCM and AACN's bundle, AACN publication of Critical Care Nurse will be best suited as their mission is stated to provide critical and acute care nurses with relevant, useful, and evidence-based information concerning the bedside care of critically and acutely ill patients, and to keep critical and acute care nurses informed on issues that affect the quality and safety of their practice, which is exactly how this Peacock question was devised. Thank you for listening to my presentation on change for early mobility and exercise implementation in the intensive care unit. You should have a great understanding of what ICU acquired weakness is and a baseline idea as to how to approach change towards progressive mobility within your critical care specialties, allowing for variational application based on the culture of your unit. After all, much like we trust that what our patients know about their own habits, no one knows how your unit works better than you. The following is a list of references if you are looking for more details.